Good morning. It's very exciting to be here. My name is Jin Ho. I'm an associate professor of oncology at Johns Hopkins. I'm also leading our program entitled Inhibition of PTPN22 for Cancer Immunotherapy. So what is the problem that we're dealing with? Well, you've heard from our first speaker and Dr. Valkulescu as well that we have made remarkable progress in cancer immunotherapy. It's now an option for more than half of the patients being diagnosed with cancer. But we still have a long way to go. And you can see in the schematic, most of the cancer types fall below the 30% response rate. And that includes very lethal cancers like liver cancer and pancreatic cancer. So we have to do better. So why does cancer immunotherapy fail? And if you know what in the immune system is attacking cancer, if you've already heard from Dr. Weiss, it's T cells attacking cancer. And if we take a car as an analogy for the immune system to go and attack cancer, there are multiple modes of failure that we can look at. It could be a steering wheel problem. The immune system doesn't have enough direction information to recognize the cancer in the first place. It could be a brake or acceleration problem. Even if the T cells get there, they might enter into a state of exhaustion and no longer function properly. Or they don't have enough co-stimulation signals to keep them going. Or it could be poor road conditions problem, where there are other suppressive features within the microenvironment that keep the T cells from functioning properly. And notably, myeloid cells is a subset of the immune system that can do this. So if we have all these problems that we try to overcome individually, we can think of a combination of 5, 6, 7 agents that's just not clinically viable. So what is a solution? A multi-pronged immune-exclusive strategy for cancer therapy. Targeting PTPN22 can overcome the low recognition problem. It can synergize to keep the T cells activated, and it can reprogram suppressive myeloid cells. So what is PTPN22? It is a phosphatase that's expressed only in the immune system. Within the T cells, it dampens the activation signals. Within the myeloid cells, it also dampens pro-inflammatory cytokines, so it's a master negative regulator of the immune system. There's also a very important genetic association with this gene. Within the population, about 10% of the US population has a dysfunctional variant of PTPN22. And in this population, about 10% of the US, higher risk of autoimmune diseases and lower risk of cancer. So it's very interesting, two sides of the same coin in this biology that we want to leverage. We have enhanced immune system and low cancer. And so to test this directly in the cancer context, we knock it out of the mice and challenge it with various tumor models. Here on the left, you see MC38 and a couple of liver cancer models. We see very strong response, even with just abrogating PTPN22 alone. And on the right, when we add PD-1 therapy, we see synergy. So we see that even with one dose, a lot of these mice actually regress completely. So targeting PTPN22 enhances the immune response against cancer. That was in the immunotherapy-sensitive models, but what about in the immunotherapy-resistant context? It's obviously the priority in the field. Pancreatic cancer is a very strong prototype of this. KP6419C5 is a very well-established model in the literature for immunotherapy resistance. It resists even a quintuplet regimen that involves 2 chemotherapy drugs, 3 immunotherapy drugs, PD-1, CTLA-4, CD40 agonists. No response in this model. Of course, PD-1 alone doesn't do anything you see on the left here. But when we target PTPN22 and add PD-1, we see that there's 40% reduction in tumor growth in this model now. When we add 4-1BB co-stimulation on top, we see a striking 80 to 90% reduction against this very high bar immunotherapy resistant model. So targeting PTPN22 can overcome immunotherapy resistance. So we want to translate this. Historically, phosphatases are very difficult to drug, but with our expertise, we're able to come up to our knowledge the first and only small molecule inhibitor of PTPN22 with in vivo antitumor efficacy. This is L1. It has reasonable drug-like properties and PK to study this in an animal model. And here on the right, you see that L1 alone can phenocopy what we have seen with genetic abrogation quite well. It's very encouraging knowing that this is a suboptimal dosing regimen. We still have more work we can do. Here we have L1078. It's a derivative of L1. It has better potency, selectivity over other phosphatases, better PK, and better efficacy. So we're doing better and better in drugging PTPN22. So what are our current priorities? We are stacking funding opportunities, working with Maryland Innovation Initiative, Harrington Discovery Institute, both very translation-focused organizations to push forward these priorities. So number one, we're optimizing the immunotherapeutic strategy further, testing tissue site dependency, dose dependency, validation in immune humanized mice. We're evaluating the toxicity, PK, and PD readouts so that we know what to look for when we're at the bedside. Number two, just as important, a major priority is continuing to optimize our medicinal chemistry. We're going to be improving potency, selectivity, and we're aiming for an orally bioavailable immunotherapeutic, so we can have an oral immunotherapeutic against cancer. You've heard from Dr. Valkulescu about the significance of liver cancer. We think that there is a very distinct opportunity here for PTPN22 targeting in hepatocellular carcinoma. It is the most common form of liver cancer. Over 40,000 patients per year diagnosed in the US, 800,000 worldwide, projected to be the third leading cause of cancer-related deaths by 2040. Very important to note, only 20% responsive to immunotherapy. And this is in the context of first-line therapy and subsequent line therapies for HCC all being immunotherapy. This is a mainstay for treating HCC, and we only see 20% response. Also, there are no FDA-approved treatments for HCC in the adjuvant or neoadjuvant setting. So there's a very distinct and large unmet need here that PTPN22 can act as a target. Even with conservative estimates for HCC in the US alone, the market is substantial, but if you think about combination with existing immunotherapy strategies and other cancer types, of course, it's much bigger. And on the right, it's very encouraging to see that in an immunotherapy-resistant model of HCC, where a combination of PD-L1 and CTLA-4 really doesn't have any significant efficacy, we see that L107-8 does. So it's very encouraging to see there's strong activity against immunotherapy-resistant HCC. There are competing targets, PTPN11, PTPN1 or 2. This really demonstrates that the field is now looking at phosphatases as a tractable class of targets. We think that PTPN22 is very distinct. It is the only highly immune-exclusive phosphatase, so we can expect a better on-target toxicity profile. When we think about other immunotherapies that are already out there in the biology, it's also very distinct. If we knock out PD-1 or CTLA-4, these mice will inevitably have very overt, terrible autoimmune pathologies, and knocking out PTPN22 does not. So in that sense, we can also expect a more favorable therapeutic index. So it's very different from current immunotherapies and other phosphatases. This is the team that's committed to the program. Myself, I'm a medical oncologist specializing in liver cancer, also expertise in high-parameter immune profiling. Dr. Elizabeth Jaffe, who is a world leader in cancer immunology and translational oncology, and Dr. Zhongyin Zhang, who is an expert in phosphatase drugging. So we have the right expertise to keep pushing forward this program. So in summary, we have a first-in-class opportunity for targeting PTPN22. It is a broad immune modulator. It can overcome immunotherapy resistance. It has genetically validated biology. It is druggable, and it's safe. So we're seeking seed funding to advance to clinical candidate selection and initiate IND-enabling studies. Thanks for listening. Happy to answer questions.